Hi everyone, I want to talk about endometriosis. Endometriosis. Have you heard about that before? Or someone close to you or yourself, you had experience of the troubles associated with endometriosis? Well, let's go. Endometriosis. What's this all about? Normally, the inner lining of the uterus is called endometrium with its stroma and glands. The lining is shed every month during menstruation. When the endometrial glands and stroma occur outside the uterine cavity, then we have endometriosis. Endometriosis should not be a problem, but the unusual destinations, which is the ectopic site and the inflammatory process after, would then lead to the problems associated with endometriosis. Vis-a-vis infertility, dysmenorrhea, that is painful menstruation, chronic pain, and dyspareunia. The cause of it is that this is a hormonal dependent condition. It is benign and it becomes a problem when it is inflamed. Before menarche, that is premenarchal age, it is rare, but don't read it out, it's even found in neonates. Menopause or hysterectomy are the only cures. In other words, it is done when menstruation stops for complete 1 year, which is the definition of menopause, or the uterus is taken out completely because this woman has stopped childbearing. Then you end it all. It's occurring during reproductive years. That is the time women will ovulate, preparing for fertilization, and so on and so forth. And post-menopause will end it. Depth of infiltration. It could be superficial when it's peritoneal lesions, could be superficial there, and sometimes at ovary forming endometrioma, and that will lead to bleeding and it will result in blood accumulation called hematoma. It could be deeply infiltrating, and that is when it's greater than 5 millimeters into the peritoneum. So it could be superficial, ovarian or endometrioma that bleeds and results in hematoma, or deeply infiltrating. The anatomical sites are ovary mainly. Ovary in about 60% of times. The endometriosis is a problem of the ovary most of the time. The anterior and posterior cul-de-sac, there are some scientific terms that are difficult to explain in such a way that everybody will get a picture of it. So, posterior broad ligaments and sacral, these are structures that are supporting the uterus itself. When you build a house, you have poles that will hold it down there. The same here. Could be fallopian tubes. That is the tube through which the egg will pass and the main component will pass and meet and fertilize, and then the content will roll back to the uterus and implant in the womb. And could be in a part of the intestine called the sigmoid colon, or in the appendix, or the round ligament, and sometimes in the lungs, and so on. Could rarely occur in more other organs. That is not to say it cannot occur, that could rarely occur. It means it is possible that it could occur in other organs, but not very common. Risk factors. Age greater than 25 years old is a risk. Nulliparity, not pregnant, not raising kids is a risk. Early menarche, starting menstruation early in life is a risk. Late menopause, because early menarche and late menopause is exposing the uterus to more menstrual months. Shorter menstrual cycles, less than 27 days, means the individual is going to have more menstrual cycles in a year than somebody having the menstruation in every 35 days. Okay? Heavy menstrual bleeding, obstruction of menstrual flow, exposure to diastereosterol while in the womb, low body mass index, sexual abuse, unsaturated fat, and of course, genetic factor. What are the factors that may decrease endometriosis? Multiple births. I'm not soliciting for that. I'm not advocating for that. Please don't raise the number of kids that you cannot cater for. Breastfeeding for a long period of time is an advantage. Late menarche, that is, onset of menstruation first time in life starts at the age of 14 or 15 or greater. Omega-3 fatty acids, I cannot prove that, but it's found in the literature. It is higher in Caucasians and Asians, lower in blacks and Hispanics. Use of oral contraceptive pills would decrease the level. Pathogenesis. Though not fully understood, but Simpson's theory will put it forward that there is retrograde menstruation and that endometrial cells will flow backwards through the fallopian tubes into the peritoneal cavity during menses. Immunological theory had it that altered immunity will lead to decreased clearance of transplanted endometrial cells from pelvic cavity and probably due to decreased natural killer cells activity. Premenarcheal endometriosis will include the existence of Mullerian embryonic rest and that the lesions are the result of neonatal uterine bleeding. 5% of newborn females will have physiological bleeding secondary to the withdrawal of progesterone from the mother. Direct lymphatic flow from uterus to ovary could be responsible for the ovarian cases. Epidemiology. 15 to 30% of premenopausal women will have endometriosis, and they are between the ages of 25 and 30 years. It decreases after menopause. So are you going to pray that women with endometriosis should quickly become menopausal? No. What are the possible differential diagnoses here? It might be ectopic pregnancy because, when the ovary is involved, the pain will be at the flange. And ectopic pregnancy is common along the fallopian tube, the fimbriae and the ampulla. And that will be on the flanks. So rule out ectopic pregnancy in this woman with everything that you could use to dictate ectopic pregnancy before jumping to conclusion. I have made a presentation on ectopic pregnancy. You can check that out right now and get the facts. Could be ovarian abscess, ovarian torsion, ovarian cyst, or ovarian cancer. Could be inflammation along the fallopian tube caused appendicitis, or pelvic inflammatory disease or hemorrhagic corpus luteum. Clinical features will appear in form of dysmenorrhea, painful menstruation, but get this, it's likely going to be secondary dysmenorrhea. It's not dysmenorrhea that is occurring the first time the woman is having menses from onset, which is primary. So this has a cause, and the cause of the painful menses here is endometriosis. You can check out my presentation on dysmenorrhea, and of course the secondary dysmenorrhia, you'll see that I've listed endometriosis as probable cause. Dyspareunia, don't want to go into details of that. Dyschezia, that is painful defecation, and there's possibility of sharp, firm, and tender barb on uterosacral ligament, and that is classic. Infertility in 30 to 40% of the affected women. In fact, the pain and infertility will be what would lead them to seek medical attention. 15 to 30% of all infertile women will probably be diagnosed with endometriosis. Wow, that's pretty high. Almost 40% of women with endometriosis will be infertile, while about 30% of infertile women would have been diagnosed with endometriosis. So infertility and the pain are the two major problems with endometriosis. Urinary frequency, urgency, or dysuria when bladder is involved. Urethral endometriosis will present with hematuria. Clinical features still continue as possible diarrhea or constipation when the bowel is involved. As a matter of fact, some could make the wrong diagnosis of irritable bowel syndrome. So when we see a woman, there should be a holistic approach. Thoracic endometriosis will present with the following problems: chest pain, pneumothorax, hemothorax, hemoptysis, scapular or neck pain. So to the nurses that are in respiratory units, and a woman is having endometriosis and she's being transferred to your unit, and you're asking the question, this is endometriosis, why is she with us? This is the reason. And of course, there'll be heavy menstruation all the time. Laparoscopy is the gold standard when it comes to diagnosis. To the students, if you can't remember anything, just write down laparoscopy. And when that is done, biopsy of the endometrium is necessary. And your findings on laparoscopy is going to be Mowbray spots, endometrioma, that is chocolate cyst on the ovaries, powder-borne lesions on the peritoneal surface, peritoneal pockets, and white lesions and clear blebs. You can have cancer antigen 125, I say, but it's going to be increased. It's not going to be diagnostic. Why that? CA125, that is cancer antigen 125, is not specific to endometriosis. It could be as a result of ovarian cancer, breast cancer, endometrial adenocarcinoma, cancers along the gastrointestinal tract, but it is going to be useful in monitoring the treatment of both benign and malignant cancers, and of course of endometriosis as well. So you will know whether you are winning or not by the level of CA125, but it's not diagnostic because it's never specific. Treatment. Surgery is a definitive treatment here. And to be precise, hysterectomy, but not in every woman. Hysterectomy is done if the woman has reached the end of childbearing. Conservative surgery to those who will still become pregnant, and they can try becoming pregnant immediately after the conservative surgery. The additions are opened up, and ovarian cystectomy of endometriomas. Treatment still continues with non-steroidal anti-inflammatory drugs to handle the pain, oral contraceptive pills, Depo-provera, Mirena intrauterine device, all these for those who are still expecting pregnancy. Gonadotrophin releasing hormone agonists like leuprolide, danazol, and of course infertility treatment with clomine, beta-hydroxychloroquine, gonadotropin, and the rest. And that will be in another presentation entirely. The end of endometriosis is postmenopausal age. Postmenopausal age will end endometriosis or hysterectomy. And with that, I end this presentation. Kindly subscribe to my channel so that you can get my presentations immediately they are published. Thank you.